This is BoomerLife on CL 650.
Welcome back to the program. On the line with us from False Creek Healthcare Center is Medical Imaging Director Dr. William Yee. In this Brain Injury Awareness Month of March, it's a pleasure to have a radiologist of your caliber with us, Dr. Yee. We do appreciate your time this morning. We talked a little bit about the scanner that you're pretty keen on, this 3T scanner MRI. How recent is it to False Creek Healthcare Center?
Well, we had the scanner for about 7 or 8 years, but we just recently underwent a upgrade.
Right.
And now we can provide enhanced high-resolution images of the entire body. A fun way to look at the strength of an MRI is use an example. Let's say a 1.5T magnet is a Lexus. Well, a 3T is a Ferrari.
Oh,
okay. So
okay.
A Ferrari is in a league of its own.
Absolutely. So basically, you've doubled the capability of your scanning machine.
Well, you've doubled the signal to noise. What it is that you're now capable of imaging in very fine detail and providing images that will enhance the confidence of your diagnosis and therefore lead to better patient outcomes.
Dr. Yee, back in the day, before a lot of these sophisticated scanners and CT units were around, X-rays were basically the only tool available to radiology. And on some occasions, individuals were required to have some dye injected into their system or take a pill or something like that in order to illuminate on the X-ray a certain portion of the body. Does that technique, has that rolled forward into MRI technology, or are we talking too old school?
Actually, contrast injected medium's purpose is to enhance differences in soft tissue contrast, and so that applies still to both CT and MRI. MRI has more intrinsic contrast resolution than CT when it comes to soft tissues, but sometimes you also want to determine if a tumor is enhancing. You want to determine if a mass has lots of vascularity. You want to determine, say, with a brain tumor, whether there's any disruption of the blood-brain barrier. So we use contrast with MRI studies all the time.
So that old school stuff is still around in some form.
It is not old school. Stop using that phrase. It is new school.
Okay. Well, you see, now it's interesting because this is Boomer life, and a lot of boomers have sort of, shall we say, dated ideas about what's available in the medical world, and it's interesting and kind of fun, Dr. Yee, to get my age group a little more up to speed on what's the tools that are available to professionals like yourself.
Mm-hmm.
So let's talk a little bit about the other types of MRI work that you do at False Creek Healthcare Center, Dr. Yee. We've done a fair bit on brain work, and we'll return to brains because it's Brain Awareness Month, and I have a ton of questions for you. But talk to us about other types of MRI work that you do routinely.
Well, we image the prostate gland, and because the prostate gland is a very small organ located deep in the pelvis, traditional imaging methods have not been very successful in detecting prostate cancer. However, utilizing new generation 3T MRI scanners and multiple parameters, we can interpret images with greater than 97% accuracy for detecting prostate cancer. And prostate cancer is important because about 1 in 7 men will be diagnosed during their lifetime, and 9% of those will die from the disease.
And guys are traditionally and typically a lot more difficult to convince to pay attention to their health and those details. Are we getting any better at it in 2015, or are we still a stubborn bunch?
I think you're still a stubborn bunch, but prostate screening is really important. I think the message is out there. Prostate screening traditionally involved both a digital rectal exam,
yes,
have a finger placed in that area. Is it uncomfortable thing to experience? And also screening involves a blood test that measures protein produced by the prostate called prostate-specific antigen.
Right.
And so it's important for men who have a history of prostate cancer, who have a family history of prostate cancer, or patients who have symptoms of BPH or prostate enlargement to be assessed by the urologist, and for this PSA test to be done, and then further screening. And one of the best screening methods right now is with MRI.
Interesting stuff. Now, there used to be a rule for women over a certain age. I believe it was 50, and it became sort of recommended procedure that once or certainly every second year, a mammography would probably be a smart idea. Is there any such routine kind of thing that guys should get into with respect to prostate issues?
Well, the question you're asking is who should have a prostate MRI?
Yes.
First of all, if you have an elevated PSA or a positive digital rectal exam, prostate MRI may be the next step before a biopsy. Alternatively, you can also perform a prostate MRI about 8 weeks after a negative biopsy. So if you had a biopsy and your PSA was high, but the biopsy came back negative, then MRI is a good test to have. Certain high-risk individuals for prostate cancer with normal PSAs should also benefit from prostate MRI. If you're considering active surveillance with a previous biopsy, positive result, then MRI is suggested as another evaluation or follow-up for men.
Right.
Yeah.
But especially if you have a history of prostate cancer in your family,
Exactly.
you want to get some kind of exam at least annually, right?
Yes. And the advantage of a 3T magnet for imaging the prostate gland is that it's very effective for the preoperative staging and treatment planning. It can determine the location of the tumor.
Right.
It can evaluate the spread of the tumor outside the prostate gland. It can look for invasion of adjacent structures like the seminal vesicle or also the bladder. It can also determine if there is spread of the disease to lymph nodes or bone.
Okay. So I already talked about mammography and as it applies to women over 50 and so on. It used to be that the preference was to get a mammogram once a year. Talk to us about breast MRIs. I would imagine, who comes to you requesting a breast MRI, Dr. Yee?
Well, let's talk about breast cancer.
Sure.
A woman's lifetime risk of developing breast cancer is about 1 in 8. And women who live in North America in particular have the highest risk of breast cancer in the world. Breast cancer is the second most common cancer affecting North American women, surpassed only by lung cancer. And for a long time, mammography and ultrasound have been the diagnostic mainstays of breast evaluation.
Yes.
For one thing, mammography is widely available, is relatively inexpensive, and it's fast. So mammography is a good test for the screening purpose.
Okay.
Ultrasound of the breast provides a real-time examination without any radiation, so it's ideally suited for evaluating known or palpable breast masses. Its use in screening, however, is questionable. MRI is a very powerful diagnostic tool, and its role in breast imaging is readily expanding. Recent publication by the ACR, or American College of Radiology, stated that 3 Tesla MRI was 100% sensitive in their study of 443 patients who had a high risk of breast cancer. It found all 66 of the 66 cancers that were present. Ultrasound, however, was only 85% sensitive, and ultrasound, because it's performed by a person, is very operator dependent. So MRI at 3T is more sensitive than mammography and sonography in the detection of breast cancer and also in the characterization of small lesions. But who should be screened? Well, high-risk screening should be performed, especially in women over age 50.
All right.
MRI is useful as an adjunct to mammography in women at high risk. Also, those patients with dense breasts, and evaluation for recurrence in women who have high-grade cancer.
Well, you were recently quoted in a Vancouver Sun article about screening, Dr. Yee. So tell us about this 44-year-old patient who had just received a normal mammogram result when she found a palpable lump in her breast. Tell us the story, please.
Yes, this woman was very pleasant, and she was enrolled in the BC Cancer Screening Program, and her mammography screening exam was negative, but she felt this lump which had been slowly growing over the last 6 months, and her doctor felt it too. And so she was quite worried about it, and she came to False Creek for imaging. And I performed the ultrasound myself, and I picked up a 2-centimeter solid, suspicious-looking echopore or dark lesion in her breast.
Right.
And so I contacted the family physician, and he said, I think it requires biopsy. I agreed, and so we performed the biopsy, and it came back cancer. And so she went to see a surgeon and had the lump removed.
Interesting stuff. So I guess back to the first step in the process, she had a mammogram, and did the mammogram not show anything? But she came to you because she was uncomfortable and dissatisfied with the result of the mammogram?
No, I wouldn't say dissatisfied. I would say
concerned, maybe.
But there was a discrepancy in the physical exam and also the mammogram.
Okay.
So in a patient with dense breasts, the mass can be obscured because the dense tissue can hide visualization of the underlying cancer.
I see.
So that's one of the limitations of mammography, is in a patient with dense breasts.
I see. So all the more reason, if there is any suspicion or concern, to go to the next step and not be satisfied with the results of that mammogram if it doesn't feel right.
Absolutely.
And so that's why she came to you.
Yeah, that is correct.
And so what is the upshot of the case? You had recommended a biopsy, which was done and which identified cancer. Are you aware of the follow-up procedures that this woman has had since you saw her and found the cancer, Dr. Yee?
All I know is that she underwent surgery and that we caught the cancer at an early stage, and it had not spread to any other organs.
Well, that's fabulous.
Mm-hmm.
That's mission accomplished then, isn't it?
She has a great result.
Well, and so how frequently does that happen? Obviously, mammograms is a subject that I clearly know very little about. So how frequently does that happen, where there is some degree of suspicion that it may not be as it looks?
Well, as a screening exam, okay, it's you want a study which has high sensitivity.
Yes.
Okay, but it's not perfect in its specificity. So what that means is that it's not a perfect exam. It's mainly used in a patient population who has no symptoms, but you want to pick up disease at an early state. And so I would say that screening mammography I do support. I think it's a great tool for diagnosing breast cancer at an early stage. Mm-hmm. But there are certain populations where it has different specificities.
Sure.
In older patients who have more fatty breasts, it's a lot easier to see a mass or a nodule. In younger patients with a lot of residual breast tissue, that can hide an underlying tumor and make the exam a lot more challenging to interpret.
Dr. Yee, is there an age at which a woman's risk of getting breast cancer is reduced simply because of age, or is it omnipresent through a woman's entire life?
In general, we don't do screening in more advanced age because when you detect the cancer, what you want to do is you detect it early, so it'll have an effect on the patient's longevity.
Okay,
how long they live.
Mm-hmm.
And so there is some controversy over when breast cancer screening should occur or what age, but particularly for women over age 50 with high risk factors, they should undergo mammography.
Gotcha. Now, back to that woman that you were quoted about in The Sun, and this 44-year-old woman who found eventually through the MRI procedure that cancerous lump in her breast and had the surgery. How long did it take her from the time that she showed up at False Creek Healthcare Center, Dr. Yee, until she had her MRI and there were some tangible results to talk about?
Oh, I'm sorry. She had her ultrasound.
Ultrasound.
Yes.
I'm sorry, that was me, because you told us that you conducted the ultrasound yourself.
Yes,
right.
That's right.
So my terminology, my slip.
Yes. She had the ultrasound, and she called in. She had the ultrasound booked within 2 days. The test was done. The pathology result was available 3 days later. Her doctor then consulted the general surgeon, and she had surgery within 2 weeks.
So talk about the peace of mind factor. This is, as if the prospect of dealing with cancer isn't unnerving enough. The fact that you were able to get the process, the diagnostics, and the remedy at least organized in that brief period of time must have been just an enormous relief for the woman in question.
Yes, actually, that's not an isolated event. We perform imaging in a very expeditious manner at False Creek, and we perform high-quality imaging, and patients really enjoy their experience here at False Creek.
Now, you mentioned back to the story of the young hockey player who came into you to the urgent care center and ended up having an MRI in an evening. So, is it realistic to say, or reasonable rather, to say that if you're in trouble and you need a scan of some kind, regardless of the time of day, if you pop over to False Creek Healthcare Center, you can probably get one done?
The urgent care center closes at 6 p.m.
Okay.
So if you're seen here before 6 p.m., then you will get your imaging and you will have peace of mind.
Right, and certainly a phone call, and if it's closed tonight, you can get there in the morning, right?
Absolutely. You can come here in the morning, and you'll have myself or one of my colleagues from Vancouver Imaging interpret your study, and your doctor will be notified right away if there is something serious going on.
Interesting stuff. Our guest is the medical director of imaging at False Creek Healthcare Center, which is at 555 West 8th Avenue in Vancouver, and online at falsecreekhealthcare.com. We'll take a quick break, and we're back with more with Dr. William Yee here on BoomerLife after this.
Canada's only weekly radio show dedicated to the baby boomer lifestyle. This is Boomer Life on CIL 650.